Good morning and welcome. Thank you for joining Silver Hill Hospital's virtual grand rounds on rethinking psychotherapy and the significance of the therapist. I am Ann Romano, the Director of Library Services and CME Coordinator here at Silver Hill Hospital. Our speakers today are Doctors John Allen and Michael Grote. John Allen holds the position of clinical professor as a member of the voluntary faculty in the Department of Psychiatry and Behavioral Sciences at the Baylor College of Medicine in Texas. He retired from clinical practice after 40 years at the Menninger Clinic, where he taught and supervised fellows and residents, and he conducted psychotherapy, diagnostic consultations, psychoeducational programs, and research on clinical outcomes. His books include Coping with Trauma, From Self-Understanding to Hope, Coping with Depression, From Catch-22 to Hope, Mentalizing in Clinical Practice, Restoring Mentalizing in Attachment Relationships, Treating Trauma with Plain Old Therapy, and Mentalizing in the Development and Treatment of Attachment Trauma. Michael Grote is the Chief Clinical Officer at Silver Hill Hospital. Dr. Grote trained in psychoanalytical psychotherapy and family systems at the Austin Riggs Center, studied psychoanalysis at the Center for Psychoanalytic Studies in Houston, and was Associate Professor of Psychiatry and Behavioral Sciences at the Baylor College of Medicine, where he also served as the Director of Adult Services at the Menninger Clinic. He was previously the director of Menninger's Professionals Program, and prior to Silver Hill was the president of Cooper Reese, a residential treatment center in North Carolina. There will be an opportunity for questions at the end of the presentation. Please open up the Q&A link in the top right of your screen, 2 speech bubbles with a question mark. Please feel free to ask a question at any time during the presentation, and they will do their best to answer within the time frame of this event. Please note all lines are placed on mute. And finally, for CME and CEC credits, our attendance sign out and evaluation survey will be published in the Q&A link towards the end of this presentation. So please look for that link. I will now turn over the call to Drs. Allen and Dr. Grote.
Thank you, Anne, for the introduction, and thank you all participants whom I'm unable to see, unfortunately, for joining us. And especially I want to thank Michael Grote for inviting me to do this, and just let you know that Michael and I work together very closely for many years. We've done a great deal of teaching together, mostly patient education, but professional education. So it's a real pleasure for me to be able to teach with Michael again. I will say I wish I could be there in person, especially since I grew up in an adjacent town, Wilton. So hopefully someday we'll be able to do this in person, but we're glad to have this opportunity. And I'm glad to have it because I've been working for the last 2 years on a book called Trusting in Psychotherapy, and it's from that work that this presentation originates. And I want to say something about trusting in psychotherapy to give some context. There are 2 senses of the word that I use deliberately ambiguously. You can trust in psychotherapy as a kind of form of treatment, just as you might trust in medicine or surgery, or not trust in psychotherapy or surgery or whatever. You could trust in the methods, like you could trust in CBT or DBT or psychoanalysis. So that's really trusting in the procedure. And that's one significant aspect of trust in psychotherapy. The other, though, that is, I think, of more concern to us, certainly me and Michael, is trusting in the person who's doing the therapy, trusting in the therapist. So that's a broad context, really, that will define this discussion, is trusting in the treatment and trusting in the therapist. And they obviously, ideally, will go together. I want to start by telling you an odd story. The odd story is this, that I saw my first psychotherapy patient in 1968 when I was a senior undergraduate. That's the odd part. I don't think anybody today would send an undergraduate to see a psychotherapy patient. It was in the psychology clinic at the University of Connecticut. So the thing is, it was not completely crazy for one reason. The one reason is that the patient had speaking phobia. He got a new job where he had to give talks, and the treatment I was to do was systematic desensitization, which is a very straightforward procedure. You teach relaxation, you have the person imagine a hierarchy of increasingly scary speaking situations, and you have them imagine going up that hierarchy while they maintain relaxation, and amazingly it works. And it did work with him. So as an undergraduate, I could do that competently. But something really problematic happened, which is as he got better, he didn't want to do the desensitization. He wanted to talk to me about problems in his life. I was clueless. So how do you talk to somebody about problems in their life? And that problem has plagued me for the last more than 40 years. That was over 50 years ago. But it sets the stage, I think, for what I want to talk about psychotherapy. And I moved to the other end of the spectrum from a kind of, it was evidence-based, quote unquote, I guess it was behavioral more than CBT, but I moved from one end of the spectrum, doing a very specific symptom-focused treatment, to ultimately winding up at the Menninger Clinic, where we were seeing, as you at Silver Hill will be very familiar with this, we were seeing patients with severe multiple problems, all embedded in problems in their life, which mainly involve problems in close relationships. And so I went to the other end of the spectrum. So my experience has been, I think of myself as a generalist, sort of talk therapy, generic therapy person who more or less took all comers and try to help them in whatever way I can, as contrasted with the kind of specialist symptom-focused procedures. And I value those procedures when they're indicated. I just they wouldn't help us all that much with these complicated life problems. The other thing is I specialized ultimately in treating trauma, with an emphasis on trauma and attachment relationships early in life and later in life. And of course, trauma brings forth the entire spectrum of psychiatric problems. And it's very important in this context because trauma in attachment relationships is where the most profound distrust originates. And the bane of the psychotherapist, the generalist, is that what the patient most needs is to be able to trust somebody what they're least capable of. And that's the trouble that we're in here.
And John, I want to add something to build on that. So one of the things that's particularly exciting for me about inviting John to be here today and to walk through a dialogue about the role of trust in psychotherapy is that, we want to do a few things today. One is we want to provide basic education on the research and the evolution of research on psychotherapy outcome and where it stands today. I think some of the findings are extraordinarily helpful for all staff to be aware of for a couple of reasons, one of which, as therapists, as clinicians in various forms, as staff members, we both assert that there is a process, a potentially developmental process of becoming a healing agent. And we're going to talk a little bit more today about some of the ingredients that the research is very clear about go into being a trustworthy partner in the treatment process, from whatever role we might occupy in the institution. The other element of that's particularly exciting is that we are in an era right now of a multiplicity of different types of treatments. And we use some of those treatments here at Silver Hill. We know that we use DBT, which has been originally developed for treatment of borderline personality disorder. And what we want to do is not only think about diagnostic specific treatments, but to enlarge the scope to really think about the role of the person from whatever position you might occupy at Silver Hill, and the very valuable role and contribution you can make to healing. And so, John and I have talked extensively over time about the kind of identification that therapists can, and a sense of identity that can develop as therapists. So we might think of ourselves as psychoanalysts, as cognitive behavioralists, as dialectical behavioral therapists, which has value. But I think today we're going to be outlining and making a case for going beyond that, and to really looking at a way of thinking about ourselves, a way of thinking about the work of Silver Hill in a much broader fashion than a specific brand of psychotherapy. And that to me is what's most exciting about what we're going to be covering.
Good, thank you, Michael. And it's a perfect segue, because what I did in working on this book, Trusting in Psychotherapy, I took, first of all, I felt like, okay, I got to get a good grip on the field of psychotherapy, what's going on in the field of psychotherapy. And I came up with, it's a book on the history of psychotherapy, this term, the psychotherapy jungle. And it's a perfect metaphor. The field of psychotherapy, I'll just say, it's a mess. It's a jungle. It's so complicated. There's so many ways to go, so much happening, that it is really hard to get your bearings in that jungle. And one of the things that's emerged, and we're going to talk about this in a bit more detail, but it really led to a shift in my thinking about psychotherapy, that most of the research is on different brands of therapy and their effectiveness, and if they're more or less effective than other brands. The vast majority, a mountain of federal funding has gone into randomized controlled trials comparing therapy A with B and C and so forth. So the irony is that the brand differences are not as important as the differences between the people who do the therapy. The therapist who is employing one brand or another actually is a more powerful influence on the outcome than the brand. So I'm leaping ahead a bit, but just so you have a context, basically where I moved is I thought, well, we put all this decades of effort into developing brands, and there are hundreds of them. Peter Fonagy, our colleagues, counted 426. I don't know how he did it, but their consensus would be that there are hundreds of brands of therapy, and we're putting all the energy into developing therapies, and maybe we should shift our focus to developing therapists. How the development of the therapist, if the therapist is more influential than the method that the therapist is practicing, then we ought to at least be putting a lot more energy into that. So that's the gist of where I'm heading here. Now, trust is really interesting to me. I ask, I'm not going to ask you, but if I did, the question, how many of you think trust is really important in therapy? I've asked patients, I've asked therapists, I've asked students. Everybody thinks trust is really important. Now, if you read the therapy literature, what you see is that there are allusions to trust. The word is used in passing, but it is extremely rare for any therapy to focus its efforts on trust. There are two that I know of. Peter Fonagy developmentalization-based therapy, John Gottman with his couples therapy, both of them late in their careers, after having done tons of work, both of them independently said, hey, trust is actually the key thing here. Maybe we need to really focus on that. That's the exception. Even attachment theory, I've spent much of my life Again, you see these passing references to trust, but trust is not something that people say, hey, we got to take a serious look at trust and study it in detail. So that's what I've decided to do. The other thing is, when we do think about trust, we mainly focus on the patient's problems with trust. The patient has a problem with trust, and we've got to work on it. The problem is that trusting requires trustworthiness. And if you've got patients who come with a history of trauma and attachment relationships, they have come reasonably and rationally to be very distrusting. And because they have not been met with trustworthiness. So if we shift the lens, we need to think about, okay, what makes trust possible? Trustworthiness. So if we could take a look at the next slide. We've neglected the trustworthiness of the psychotherapist, and I've come to believe that before we think about, okay, this patient's got a problem with trust, we ought to think, okay, so what do I need to do to become trustworthy to this patient? I think we tend to take for granted that we're trustworthy and they ought to trust us. That's my view. Really, I think we should assume that we will not be trusted and that we have to earn their trust. And it will be a long, difficult effort.
John, I think I want to add some color to this important comment, because I think that's what you're outlining is, you know, you're questioning a basic hypothesis. And the basic hypothesis is that as therapists, we can have an ideal, a self-ideal, that of course we're trustworthy. However, if we examine it from the point of view of the patient and their experience, and really think about this from a patient experience point of view, they may not consider us trustworthy at all and have potential very good reasons for that based on their history, based on their experience of what it means to rely on other people. Have they experienced them as trustworthy? Have they been let down? Especially when, you know, at Menninger and even here at Silver Hill, working with people with a lot of complexity who have been through numerous treatments, who may come to us with a lack of hope, with a sense of what hasn't worked, and with an acute sense of the nature of the vulnerability of what risk means again. And so I think when we start talking about this domain, I think what we're pointing out is that even the assumption that people will experience us as trustworthy needs to be met with curiosity and a stance of not knowing for sure that we can assume that.
Yes, and I would go further to say that actually we can't take our trustworthiness for granted because we don't know. We don't know how this process is going to go. We can count on, with these patients who are, we can count on making mistakes, on letting them down, on being off, and limitations in our trustworthiness. And so it's the process of accepting limitations in our trustworthiness and working to repair things when they go wrong, that's going to really make us trustworthy to them. So an attitude of profound humility, I think, would kind of summarize what I would say. Could we take a look at the next slide? So let me just say something about the word trust. The trust has many senses. I'm writing about this. It's an enormously complicated idea, but let me try to cut to the chase. So if I tell you that I trust my car, you shouldn't look askance. That will make some sense to you, because it's connected with reliability, and trust is connected with reliability. So I trust my car to get me to work. So we could say, okay, that's a rational statement. Then let's say, okay, I need a friend to take me to work. So I could say, okay, I trust my friend to get me to work. Now this underscores the difference. The car, my car at least, does not give a damn if I get to work. This matters none to the car. However, my friend hopefully does care that I get to work. So here's the fundamental difference. There's an Australian philosopher, Karen Jones. She uses two words for trust: counting on. If you remember nothing else about what trust means, counting on, to count on the person. Michael would say in the groups over and over again, you know, this person has my back. That's the sense of counting on, that you're counting on someone. So I can count on my car in one way, but my doesn't care that I'm counting on it. Whereas if my friend is trustworthy, she will care that I am counting on her. An interesting question to ask a patient who comes to you for therapy, if you're interested in trust, you can say, tell me, what are you counting on me for? And then you have to, you know, do you care that they count on you for that? So this is really crucial. Basically, trustworthiness is response to the fact that somebody is counting on you. Now, we could think of it also as a kind of, we create a we, that is, we are working together toward a common purpose. The common purpose, broadly, is the patient's well-being. The patient has a role in that work, we have a different role in that work. Now, if we can be counted on, then this means that the patient is less vulnerable. I've got to back up and say, people are afraid to trust because it makes them vulnerable. They need to trust because they need to depend on somebody. They need to be able to count on somebody because they can't do it, whatever it is, on their own. So they feel vulnerable, and that's a big reason for distrust. The value of trust is that if you can trust somebody who is trustworthy, it makes you less vulnerable. Our patients are especially vulnerable because they're out there trying to make it on their own, and they don't have the resources to do it without help. So that would be the pitch, in a sense, for trusting, is that it reduces your vulnerability. So I've already covered the two senses of trusting. A very simple idea about what we trust in is we trust in care and competence. It's a very broad distinction. So the patient needs to trust us to be caring, as I've just been talking about, and they need to trust us in being competent. So the caring has to do more with the personal qualities of the relationship, and the competence more to do with the professional background and so forth. I like the idea, this comes from the philosopher Kant, is respect. If we can get that right in relationships with patients and others, we really got it. The Kant's idea was that a good relationship involves a balance of love and respect, where he thinks of love as coming close, connecting, and oddly, respect as keeping distance. It's a beautiful idea about respect, and the two of them, that we need to balance closeness and distance. So distance means giving the person space, promoting their autonomy, and love means supporting, coming close, compassion, affection, and so forth. So it's obvious that what we would like, you go to a doctor, you like both, right? You'd like caring and competence. And it's easy to imagine a kind of 2x2 where you have, you know, both, neither one or the other. Somebody who's very caring but not particularly competent, somebody's very competent but not very caring. And we've all experienced these combinations in our encounters with people and doctors, I would imagine.
And John,
So,
one thing I want to add to this is, you know, this whole notion of these kind of intertwining dimensions of self-directedness and relatedness really goes to the heart in many ways of, kind of broadly speaking, you know, how we're approaching the therapeutic endeavor. We have patients come in, we are working to partner with them around their goals, what is it they're looking to accomplish, what speaks to that element of self-directedness, as well as staying connected with them in a partnership that ultimately we want to be in the direction of trust. And, you know, Sid Blatt and others have talked a lot, and he looked at the kind of developmental process of self-directedness, and relatedness, which one of the things we've learned from all the research on attachment is that being attached in a trusting relationship actually enables us to be more self-directed. Right. So there are so many positive developmental outcomes when we can partner in respect, precisely what you're speaking to here.
Exactly. All this fits together. It's very cohesive, really. We've got Blatt, attachment theory, and then Kant with the fundamental moral basis of it. So I just want to cite these resources. We see we're lucky here, those of us who really want to get a sense of the psychotherapy field, because there are task forces for decades who have been working on integrating and summarizing the research on psychotherapy. We've got, over a half century of research on psychotherapy. It's mountainous, and there are some very good resources. This and the next slide just list some key resources that have pulled this knowledge together. And what I'm speaking to is what I've taken from meticulously going through all this synthesis of what. Now, one caveat here is that most of the research is on short-term CBT treatments. So that's a limitation, because it's the hardest work, I think, is in the trauma literature, where these short-term therapies are they may be helpful for limited problems, but we really get into the jungle and the weeds. So if we could go to the next slide, this battle is the word that comes to mind in the field, is between the people who are helping and promoting brands and those who are saying, like I am, that actually it's what's common among the therapies that it accounts for most of their effectiveness rather than brand difference. And the point of this slide is the year it was written, 1936. Saul Rosenzweig was a psychologist at Harvard, and he was, this was way before these hundreds of brands emerged, but he was looking at all kinds of healing practices. And this is unbelievably prescient, I think, that you have the effectiveness of the therapist as a person, the theory that they use, and that this is all adapted to the particular problems of the patient who is ill. He used the word sick, which is not appealing, but otherwise, I think this is basically right. And he said, it is necessary to admit more elementary considerations. Certain types of disturbances might be an indication for certain kinds of therapy. And that's where I think there's room for generalists and specialists. So I'm not saying that we don't need these specialized procedures for symptoms, but that most of us are dealing with what I came to call plain old therapy, doing whatever we can to help people using means. And if we could take a look at the next slide, Frank was the one I was quoting for a long time, which is simpler than Rosenzweig. Much of, if not all of the effectiveness is due to what they have in common. And Rosenzweig and Luborsky, who was a Menninger psychologist, both used the idea of the dodo bird verdict from Alice in Wonderland. All have won and all must have had prizes. So the news is therapy of all sorts works, and bad news, overstating it, is that we have no idea which one is better than any other.
John, so I do want to, John, I want to go back to this last slide, Rosenzweig's comment about a system of concepts which they had mastered. We're going to say something about the system of concepts that are mastered, because not only is it the effective personality and the approach, but that there is a conceptual framework to the approach of care for the patients. So it's not that anything goes, but that there are guiding values that orient us in the work.
Yes, I'm gonna come back to that. It's a crucial point. And a related point is not like any therapy that anybody does is equally effective. These therapies that are studied are all, quote, bona fide therapies. I mean, it's not like you can do it at all and it's going to work just as well. These are solidly well thought out and researched therapies, of which there are many. Now, this slide is what I did is, this is the book by Wampold and Immel. It's a really, if there's one book you're going to read, this would be a great one, because it's wonderful in many ways. But what I did is I just listed in order of contribution to the therapy outcome, what helps most, what helps least. The most helpful things: operations, part of the alliance. Rogers is in here: empathy, positive regard, genuineness. All these things have been shown in aggregate research to be very strong contributors. And therapists, naturalistic, that like plain old therapy, the therapist individual differences are very important. Outcomes, feedback. Now, when you do therapists with randomized controlled trials, the therapist effect is not so great because the therapists are doing manualized treatment. So you take out the individual differences in the therapist, which ironically then means that the potency of the therapist is less significant. Of course, this is important if you want to look at the brand versus the therapist. Now, once we get down to 10 and below, these are small effects, and these are all to do with the brands. So this literature suggests that the common factors contribute more to the outcome than the brand-specific factors. So if we could move on from that. Now, there are a lot of caveats here. And this goes back to what Michael said, that you've got to have a treatment. You've got to have a brand, a something, some kind of, and Wampold is emphatic about this. You can't just have a good relationship and say, okay, Rogers actually believed that. A good relationship is what you need. Patients have problems, they've got to be addressed. The patient needs to take action in relation to those problems. So you need a treatment. So thinking about common factors apart from an effective treatment makes no sense. So that's the thing where you really can't pull these apart. The problem for the therapist becoming trustworthy is, man, it's hard to decide kind of treatment you ought to be using. And I think there are different styles and people have different preferences for one sort of thing or another that will guide what they gravitate toward. But as Michael said, you've got to know what you're doing. You've got to have a coherent conception of it and some method of working with it. I also need to acknowledge that many people dispute this dodo bird verdict. And again, if somebody's got a specific symptom for which they're a treatment like systematic desensitization, go for it. There's some evidence that for specific symptoms, a treatment that is dedicated to it and proven of effectiveness will be more effective than a treatment that is not. Surprisingly, not hugely effective, but if you say, look, I got two medicines, this one's a bit better than that one, which one do you prefer? Well, take the one that is a bit better. The common factors are really powerful, but there are differences here. And the key thing is that the methods must be credible to the therapist and the patient. Therapist has to have conviction in what they're doing, and the patient has to share that conviction.
Yeah, so just as a nice point, John, that if a patient believes, or at least is open to, the possibility that attention to one's cognitions or thought patterns and maladaptive beliefs will be helpful in alleviating the experience of depressive affect, then that's a good example of there being something credible and shared between the patient and the therapist. However, if a patient is not, quote unquote, on board with that, then we, I think, are looking at a process of engaging with the patient around what would be helpful, meeting them where they are, thinking about the elements of motivational enhancement, and sometimes, and I think you were speaking to this, there may be limits to what we can do as a psychotherapist with a given patient. And, this is a call for increasing our flexibility as we think about the developmental arc of our work as psychotherapists. One model would be to say, well, this patient is not particularly open to a cognitive approach. I should refer them out. Another stance might be, well, what is it that I need to learn about as a therapist to expand my repertoire, to expand my range of ways of working, that I can better meet the needs of this given patient and other patients like this patient. That's a very different kind of more developmentally oriented stance. And I think it demonstrates a certain kind of flexibility and lifelong growth that I think mirrors the direction of the literature.
Yeah, I'm going to say more about that, but I love that emphasis on flexibility. This is really a key. Therapy gets into trouble when the therapist is not flexible. And we all tend to do, if something's not working, we tend to do it harder. And it just makes things worse. So I think flexibility and humility would be a good combination. So there are some other complaints about the common factors. They're complicated. The research is correlational. Like you have a better alliance, you have a better outcome. Well, maybe it's because the patient is getting better that you have a better alliance. There is some longitudinal research that says that the alliance actually precedes improvement. But a lot of these common factors, it's hard to tell what's driving what. Now, the other thing, I really want to say something about this. The naive idea, in my opinion, about therapy, the alliance is the big common factor. Everybody agrees there's 3,000 patients in this research. 30,000, I mean, hundreds of studies. Now, if you read the CBT literature, you could get the impression that, okay, what you need to do is develop a good alliance so you can get the work going. The reality of our work, and I think this is going to be true of the work at Silver Hill, Michael, is you may get a good alliance going and then at the bottom drops out. And that you're back and forth. It's not like you create this and off you go happily there ever after. It's like a struggle to create a solid, durable alliance in therapy, in other relationships. We could think of the alliance, a good alliance, as an outcome. Trust, we can think of, Peter Fonagy's promoted this, not as, get trust and then you get the therapy going. Trust is the outcome, the capacity to trust, taking the trust beyond the therapy. It's a very different way of thinking about what we need to do here. We have to help people become discerningly trusting and distrusting. The other thing is the patient is a neglected common factor. Every therapy has a patient. The patient's skills, relational capacity, severity of illness, it swamps the variance associated with anything that we do. And the patient's life circumstances, life events, the environment, the family, these things are more powerful than we are. So we can have an influence, but we need to be mindful that we're bit players in the outcome of therapy that goes way beyond anything we do. And the brand's differences fall pretty far down, I would say. So now we go back to what Michael was emphasizing. If you look at the brands, they're adapted to diagnosis, but there's a good literature now. We need to adapt flexibly our approach to the whole person, cultural diversity, religion, sexual orientation, readiness for change, Michael alluded to, treatment preferences. If you honor treatment preferences, the outcome will be better. Reactants, patients who are they prize autonomy and controlling therapists, everything gets worse. You need to be more laid back. Other patients want more direction. So all of these patient characteristics that are transdiagnostic need to be given equal weight to diagnosis.
And John, I want to build on this point. I think there are several kind of societal factors which I think especially point to the significance of looking at these transdiagnostic aspects. We know with the increased attention being paid to systemic racism that we can't ignore the realities of race in the room, even a white racial identity. What does it mean to a given patient to be white, to be Caucasian? What does it mean for me as a therapist in the room with someone to be Caucasian? What does my socioeconomic and social cultural background mean in relationship to my trustworthiness or perceptions of my trustworthiness as it relates to the relationship with the patient? So I think that, if we start moving beyond brands that are adapted to specific diagnoses, which by and large, the literature there does not speak as much to these personal factors, and Norcross and others have really drawn our attention more recently to more carefully attending to the person of the patient with all these dimensions that we have here on this slide. And for those who are interested in exploring this further, John Norcross, University of Scranton, has on his website a free downloadable instrument that you can use, which I use in my private practice. It's called the Norcross Preference Inventory. And what it does is assesses patients' preferences around how directive we are, the kind of stance we take in relationship to whether we do homework or not, all these kind of various dimensions which the research literature tells us matter. And then in addition to that, really opening up a dialogue with people, I think even in a new way, and this is something newer for me as a white clinician, to engage in dialogue, what it means about working with a cisgender male of a white skin, and what does that mean to the patient?
Yes, and I just want to underscore, reading that literature, one of the things that comes through is cultural humility. The fact that we really do lack knowledge. We need the patients to educate us about their the meaning, their culture and its meaning to them, but we can't all put all the responsibility on the patient either, that we need to learn ourselves as much as we can about cultural differences, and they are huge, huge. The 96% of the research done in psychology comes from 12% of the world's population. Weird. Western educated, rich, industrialized, democratic cultures. So we are a country with enormous cultural diversity, and the basic premises from which our research, we take our research, it doesn't apply to lots of cultures, even what's, attachment theory. That's a whole other story, but I'm really glad that you underlined this because we need to pay attention to it. So if we could go, yeah, this is just some research on therapists' effects, that if you study a large group of therapists, you look at the outcome, you find a group that's better, a group that's worse, a group in the middle, and the better group does twice as well with outcomes than the worst group. That's a significant effect. A small proportion had no positive outcomes. That's pretty scary. A big point. Therapist effects 4 times more prominent with severely disturbed patients. In other words, if the patient has mild problems, what we're talking about is not so significant here. The therapist, any kind of reasonable therapist, will be able to do a good job. The differences among therapists really come to do with the most difficult, challenging patients. I'm sure the same would be true in general medicine. That you don't need enormous skill when the problems are fairly easy. So but it's a very important point. And of course, therapist effects are going to be more prominent with some disorders than others. If we could take a look at the next one. So individually, I think we touched on this. Some therapists are more effective with some problems than others. Manuals trained therapists are changeable, but lots of therapists adhere to the manual. But here's this bottom point is very important. Therapists overestimate their effectiveness and are relatively unaware when patients aren't getting better or deteriorating. So this is a huge problem. Brings us to the next slide. therapist's effect on outcomes, that title actually isn't, it's misleading. Outcomes research improves treatment outcomes. In other words, if you monitor outcomes of the treatment, that is how symptom change progression as the treatment goes on. Monitor the therapeutic alliance. That improves the outcome. And especially when the patient is not doing well. That's when monitoring outcomes really makes a big difference, especially when there's deterioration. Yeah. So we need to do that. That's where we really need to put in energy.
And John, just to add to that, if you think about it from the point of view of if you have someone for whom trust is critically important and potentially fragile, and who may not be comfortable letting you know that there's, or has difficulty verbalizing that there's been a rupture or a misunderstanding. I'm using rupture in terms of misunderstandings, impasses, felt places of disconnection. If that's not expressed, these outcome measures can help give an outlet to those kinds of places of disjuncture and allow attention to be paid to them, allow entire treatment teams to pay attention to them. And one of the things that was very exciting to me is that here at Silver Hill, we are now in the process of launching outcomes assessments throughout all of our programs. We started with the adolescents, now we're moving to the adults. And I know outcomes work has been at the Menninger Clinic for a long time now, a very robust tradition of use of outcomes and using them by the individual therapists and the treatment teams. And time and time again, a lot of the outcomes kind of mirror what you're learning in the therapy, but in those situations where outcomes pointed to something that was not known or underappreciated, it could really be a turning point in the treatment. So I'm just underscoring the significance of how outcomes can be an enormous value add for psychotherapists and for just the treatment in general.
Right, and there's research to support that. So I think, it's hugely important and underused. So let's go. I'm going to say something very brief about a tendentious topic here. Research does not show that more experienced therapists are more effective than less experienced therapists. That might come as a shock, but it's not been demonstrated that experience makes a difference. And then on top of that, if you compare the effectiveness of therapy 40 years ago with the effectiveness of therapy today, you find that it hasn't changed. So we've developed hundreds of brands, and overall, the enterprise of psychotherapy has not become demonstrably more effective. So this is a cold shower here. One take-home message is that just continuing to do the same thing for more and more time is not going to improve your practice. This really was instigated by, people looking at expertise in other professions, that it really has to do with deliberate practice. You really have to work at something that is tied to practice. The trouble is, I couldn't tell you, you say, well, what should I practice? Well, it depends on what kind of treatment you're doing, the kinds of patients you're working with. But the point is, we really have to work at it to get better. Maybe we could go to the next slide.
Yeah, John, and I think it would be, as we go to the next slide, to talk about this kind of seeming paradox, because just a moment ago we were talking about back here, therapist effects are more prominent with severe disturbance, or you might say complexity, right? So we have, on the one hand, more effect when you have severely disturbed patients. On the other hand, more experience may not necessarily lead to a better outcome. So there's this kind of interesting contrast of having more experience can help someone deal with increased complexity, yet it's not necessarily experience alone. So I'm going to move on to the next point, which I think is relevant to, ongoing development as a therapist.
Yes, I think I like the idea of psychotherapy as a craft. And I think of it, the mastery of a craft is the work of a lifetime. And what's become prominent in all this literature since the brand differences are waning is, okay, so how do we go through this jungle and integrate, what would be most valuable? You have the common factors. You could combine techniques from different approaches, combine theories. Everybody's trying to figure this out. I like this idea of assimilative integration because it's a developmental point. I started with systematic desensitization, quickly realized, hey, man, I don't know what I'm doing when it comes to more complicated problems. So over the lifetime, you integrate and pull things together. It's a developmental process. I would say the work with an individual patient is a developmental process. It's a developmental, we come from the psychoanalytic tradition, which is the beauty of it, is it's developmental. And it's just a way of thinking that we need to create a developmental process that moves development forward. So we have the development of the patient, we have the development of the therapist, and the trouble is now there's different types of integration, a couple dozen approaches, so we have to integrate the integration. There's just no way to get out of this therapy jungle. That's one thing I'm convinced of. We have to find our way through it. Maybe we could move on. I'm not going to go. This is just me. The number of things that have influenced me over the course of my career in more or less chronicle overlapping order. And there's even a bit of something that's more like CBT, the work with suicide. That's more structured approach that I learned late in my career. And I came up with something that I think is extremely helpful, which is writing. I call it a personal formulation for my therapy patients. Once we've worked together for a bit, writing down my understanding of them in very personal, not clinical, very personal. It's more like a letter to the patient about how I'm thinking about them. And that's something that I think is very useful.
Yes, John, and having seen a number of your letters over time at Menninger, they're quite touching and really personalized to the person of the patient, and they're just really lovely. And I know recently we asked you for an example of such a letter that we can learn from here as we're looking at launching our assessment service and can provide somebody a personalized narrative about them. And just, I love that you're outlining your lineage in a way, or your history. Reminds me of my own work and development as a therapist, starting out in education, where I began my career in higher education, and thinking a lot about educational interventions, and then moving into psychology. And in particular, getting trained in cognitive behavioral work all through graduate school, and then being introduced to the psychodynamic tradition and really resonating with its developmental perspective in particular, and then studying psychoanalysis. However, even during my tenure at Menninger, studying psychoanalysis also was studying in-depth mentalization and attachment work, or mentalizing and attachment, and David Jobs' work on CAMS. And in the more recent times, have been studying the unified protocol. In fact, I'm leading an inpatient group which pulls from the unified trans-diagnostic protocol. So just in thinking about, I love that you're outlining a developmental process here, because learning the craft of psychotherapy, I think, really is a lifelong process, which is one of our main points for today. And it does require a continual learning, and it's beyond going to one or two different seminars. It's really devoting ourselves to learning and expanding our repertoire of skills and understanding, and being able to meet people in all of their complexity.
Yeah, I just want to add something to that. There are brilliant people in this therapy integration movement, and they start. Some of them start from CBT, and they say, okay, wait a minute, this isn't working. You know, and then they move toward more dynamic thinking, and then there are people who start from dynamic thinking, and they say, well, this isn't working. Wait a minute, they move sort of more toward CBT. I don't know if it's more research that over time therapists do tend to be more like each other, but it's finding common ground. Maybe just before I stop, a couple of slides on the therapeutic community. I think of individual therapy as preparatory. That is, it prepares people for becoming more socially integrated in the wider world. There are people who spend their life in therapy. It's not necessarily a bad thing, but it's not a good thing if it prevents them from developing other relationships. You know, some people have been traumatized. They think they've found the one trustworthy person on the planet. And, you know, so they stay in that relationship. But really, it's moving out. I once said in an education group, psychotherapy should be a bridge to other relationships, and it's hard to get on the bridge. And a patient wisely said, I can tell you, doc, it's harder to get off the bridge. And so I think really it's that bridge that we need to think of therapy. And the crucial thing, again, this is from Fonagy, it's the generalizability of trust to others in the social world. So if we could have the next one. So then I thought, well, if you bring other people onto the bridge of the therapy, that's good. Family members, group therapy, couples therapy. And of course, the therapeutic milieu is powerful. We know that. Michael and I have spent years in these institutions. The community, a therapeutic community, is really powerful because it helps people, you know, way beyond psychotherapy, develop relationships, and peer relationships. Ultimately, they're the crucial relationships of us. And then the other thing is, of course, how effective psychotherapy can be depends on the social context, the patient's social context. And trust, as just to state the obvious, I find it ironic to be writing about trust in this political climate where there's literally an assault on trust. So this now, I think our lives are far getting complicated around trust because the climate is antagonistic to trust. Wherever you stand on the political spectrum. So it's a timely issue and a wickedly problematic one. That's my final word.
Yeah, and you know, John, I want to build on what you're saying about the significance of the therapeutic community. I mean, one of the things that you know, we talk about at Silver Hill, and I hear from various staff members, is about the soul of the community, the heart of the community, the connectedness of the community, a sense of being in it together, and which is hugely significant to staff as well as our patients. And I love this way of thinking about the therapy as being a safe haven. You know, the attachment literature talks about the secure base or the safe haven whereby people can come to trust their own mind and develop trust in the therapist, trust in themselves, and be able to move out into the broader social world. And so one of the things that I think is useful is, if we even think about human development, to move from the dyad, which, you know, is personified in the kind of the infant relationship on a caregiver, growing from that to move outside that dyad to triadic relationships, moving from triadic relationships to being part of a group, which is what we see occurring normally within adolescent development and young adulthood, and then also with that process joining a community. So I think that, you know, as if we think about the role of the psychotherapy in the context of a system, we are helping facilitate connectedness on many different levels, not only the individual dyadic level, but helping facilitate relationships at the triadic level, the group level, the community level, and as you're pointing out, even the society level, which right now we're seeing a lot of fractures and ruptures and disruption of trusting relationships, and even a disruption of civility. And so for us as an institution to hold a space whereby trust can be a founding value in something we work at, I think is a very powerful organizing principle. I mean, one of the things I think about on a regular basis in my role as Chief Clinical Officer is, what is a unifying paradigm that can bring together the staff of the entire organization in the service of our mission? And, to say that, we are a dialectical behavioral therapy hospital, or we're an acceptance and commitment therapy hospital, or we're a mentalizing hospital, it's insufficient. It doesn't work. It's trying to impose a brand on an entire system. What I like is thinking about it in the context of the relationship and the trusting foundation of the relationship gives everyone in the organization an avenue to join and to contribute to the mission. So that I could be thinking about my work in patient accounts and the work I do in terms of relatedness to the patient and how I can engender a sense of trust, not only in patient accounts, but within the organization as a whole. That can be true for people working in facilities and dining, people who are doing individual therapy and psychiatry. So I think the relevance of what we're getting at today, both from an institutional point of view and also the individual development of staff members and therapists in particular, is highly significant for Silver Hill, and I think for any behavioral health hospital in 2020, that we're fundamentally trying to think about core aspects of identity and what does it mean to be a therapeutic hospital. I want to move into zooming in on a couple of aspects before we then open it up to discussion. As I think about the work here at Silver Hill and the hospital, one of the things that we do attend to is the patient experience. And what is experience? Well, it's when you talk to people, what was it like? What did you live through? And this here is this is some research done on over 2,000 patients across the United States by the Barrel Institute, which is a foundation that studies the patient experience and does a lot of research in this realm. And what's so interesting is if you look at the studies they've done across different organizations, different health organizations across the United States, in terms of what patients say most contributes to a positive experience for them, you can see here things like being listened to, the clarity of communication, the respect, we talked about respect, the sense of inspiration of confidence, and that you take their pain seriously. And if you contrast that with what is relatively lower ranked, the age of the facility, the food, and not that these things don't matter, but if you look at just this realm of data, and this is just only one data point, there's lots of data that supports very consistent findings. These are all relational elements. And then moving on to this is a word cloud, again, based on an extensive study done across various organizations in the United States, health organizations, hospitals, mental health clinics, looking at, what are the adjectives that would best describe a positive experience. Here's what you see, the word cloud. The words that are accentuated are the ones that are most often used, and you see caring is prominent. We go back to our discussion earlier about care being joined by competence, because you also see up here competence, you see professional, helpful. Well, to be helpful, you actually have to offer something that is of help to someone and that can provide reassurance and comfort. So what's so interesting to me and relevant is that the psychotherapy literature and the direction of the psychotherapy literature looking at trans-diagnostic factors, a more developmentally integrated approach, relying on caring competence, we see these same trends mirrored within the abundance of patient experience studies and literature. And I want to end by giving a case illustration of a use of outcomes with a patient that I've worked with previously who presented to me on day one, was referred to me because has had enormous difficulty in various treatments. And her chief complaint to me was, listen, I've been through a lot of different treatments. I feel like they have often failed me in some way. I've been let down a lot, and I frankly just am not very trusting in any form of therapy being of help to me. So this is a 29-year-old woman with a history of panic disorder, generalized anxiety disorder, borderline personality disorder, and major depression. So you can hear already complex psychiatric difficulties, a person who has interfaced with the mental health system. And over time we've learned that she did gain things from various kinds of very diagnostic specific treatments. She went through 2 years of dialectical behavioral program and learned things, and it did help her. However, what she experienced as not being really addressed fully with her was her chronic sense of mistrust. And so I have here a series of outcome measures I have administered to her, which I continue to administer to her over time. And you can see series 1, which speaks to very early in our work in the first few weeks, the bond with me being rated as low. In other words, she endorsed a lot of items around, items that have to do with, I trust my therapist, I feel confident that my therapist has my best interest in mind, shaky. And agreement on our task together, shaky. And agreement on goals, shaky. Looking 2 months into the work, series 2, we see some increases in the sense of bond, still working a lot on task, trying to think about, and I'm going to say a little bit more about that in a minute, trying to think about what is it that we're sharing together as a joint venture, some more agreement on our goals and what we're working towards. And then looking at the 6th month mark, you can see a real increase in a sense of connectedness and a bond, an alliance, more of a shared agreement on the task. And so I want to open those things up and talk a little bit more about these dimensions. So this is a woman who, said, listen, not only do I not trust you, but I'm wary of being vulnerable to you, because if I'm vulnerable to you and I allow myself to hope, I could be let down again. So, one of the things I said to her early on is, of course, I mean, why would you trust me? You don't really know me. You've been referred to me. And we spent the first month and a half, twice a week, primarily looking at trust and all the different ways she has experienced herself as becoming hopeless in treatment. And during that process, I felt a particular kind of, you might call it a schematic way of relating or a transferential way of relating. There was enormous pressure for me to do things, to do something to make her better. And when I was not able to provide her an instruction on what to do to feel better, this undermined her trust. So we then tried unpacking that, slowing it down, doing a wind and review to understand the pressure, the urgency, and what we came to understand was the panic she felt about finding solutions. And then I began discovering that in the context of her very driven, achievement-oriented family, being able to achieve is a primary value. In fact, she brought that same paradigm to treatment, a very perfectionistic stance to treatment, which helped me understand more about why other treatments perhaps haven't worked. She was evaluating them critically. Her family was evaluating them critically, and frequently was not seeing the level of progress and the pace of progress that they wanted to see, which puts enormous pressure on any therapist. And so part of the work early on in terms of addressing issues of trust and unpacking it was to understand the meanings of trust. And one of the meanings of trust is, I can consider you trustworthy if you can really deliver for me. Just like my father, the executive of a major US company who makes things happen. He delivers. He expects people who work for him to deliver. And so this very same stance was being played out in relationship to me and became an early focus of treatment. So one of the things we've worked on and developed a common language around, this is a task, a common language around is signal to me those places where she's becoming impatient, those places where she's feeling that this is not delivering for me, so we can slow it down and unpack what's happening in that moment. And one of the things that she's allowed herself to do, or given herself license to do, is to tolerate the uncertainties, tolerate particularly that the results may not be immediate, to allow room for results to develop and evolve over time. And so that shared negotiation where I've been able to invite her to tell me when I'm, in her mind, not delivering enough, fast enough, and then for me to acknowledge those things and talk with her about it, and for her to tolerate the process while also looking at, are there ways that I can meet her differently, which during this process in the last 6 months, I've consulted with a colleague who does panic treatment so that I can think about addressing her panic in the most effective way. So part of this is a process of earning trust by unpacking the meaning, talking plainly. When I first started working with her, she used a lot of jargon with me. She had studied the DSM, and so we started using a language together. We started developing a language for her experience that was not about DSM speak, and me acknowledging mistakes, misunderstandings, being able to say I'm sorry, being flexible by my getting some consultation on panic, coming to her and saying, listen, I've learned some new things about panic and how I think I can help you better, and then listening to how she listens to me, and being able to attend to the fragility of trust. And what's interesting is that even last week, I had referred her out to a specialist, and she had some difficult time getting a hold of that specialist, which created a little bit of a wavering of trust in me, that would I be referring her to someone who's actually trustworthy? And so we did address that. So the fragility of trust, I think, is one of the core dimensions of work with this young woman. And John, to your point earlier, I think her moving to a place of feeling more stably trusting will be a very significant outcome of her treatment. Mm-hmm. So with that example, we do want to open it up now for dialogue with all of you who are with us on the call, and we invite your comments. Oh, Dr. Gerber has written in. So Dr. Gerber is, thank you, Dr. Gerber, for your gracious comments. Dr. Gerber saying, thank you, John and Michael, for a beautiful talk about psychotherapy. Your perspective is near and dear to me, and yes, I do know that's true. Andrew and I both share a passion for thinking very broadly and flexibly around psychotherapy and the role of psychotherapists. In fact, Andrew has frequently spoken about the relational aspect of this work as paramount. As you know, Michael's leading us through an enormously thoughtful and well-planned process of considering the future of psychotherapy here. I wonder if I could ask each of you to comment about what it's like to bring this kind of change to a hospital, Menninger and Silver Hill in particular. I imagine it's understandably scary and disruptive for those who have been predominantly using one model to hear that there are other models that are useful as well. Can you comment on what this process is like and how we can best embrace it? So Dr. Allen, I'll turn to you. And
yes, well, Menninger is an unusual case because it was developed as a psychoanalytic hospital, so it was psychotherapeutic, at the core. Although what happened with Menninger is that the world changed and people expected a wider range of therapeutic approaches, so it wasn't getting psychotherapeutic work to go, to get going, but to broaden it, to incorporate more what I think of as practically helpful modalities. DBT would be one of them, CBT. So it was really expanding it to become more eclectic. But at the same time, it's getting harder and harder, as you well know, in this climate, which I label rather critically a climate of biomania, where people are more medically oriented patients are the worst biomanics because they want the drug that's going to fix everything. So in this world, actually, I think to preserving the psychotherapeutic hospital has really become the challenge rather than developing it. So we're on the other side of that spectrum.
Thank you, John. I think in response to that question, Andrew, I think a lot about finding a common shared mental model. And over time I've experimented with, should it be mentalizing? Should it be dialectical behavioral therapy? Should it be this? The challenge with that kind of thinking, I've discovered, is that it necessitates getting everyone trained in a diagnostic specific therapy and to keep them all trained on a regular basis, which is one of the challenges we face. It's also one of our strengths, is that we have dialectical behavioral therapy, and we're very good at it here. If I were to think more broadly though, that it's not efficient to try to get everyone trained in dialectical behavioral therapy, and that dialectical behavioral therapy may not work for everyone. So then thinking about a broader framework, which I think is what we're talking about today, makes more sense, because it unifies us around a common core of the relationship being foundational, and then our thinking together around how do we develop effective relationship, going back to Saul Rosenzweig's comment, effective personalities or effective relationships with shared concepts. I think that makes more sense to me as a process of supporting organizational change, whether it's here at Menninger Clinic or other hospitals, because within each discipline, nursing staff has a way of thinking about the nursing relationship and how to foster trust in that relationship. The clinical social work staff, as they do psychotherapy, have a way of thinking about fostering trust in that relationship. The psychiatry staff, the psychology staff, I mean, all these disciplines I think can consider how to foster trust, even in all of our other departments, patient accounts and admissions, and what are all the things that we can do to facilitate trust. And I do think there is overlap between developing trusting relationships and patient experience. I think some of the customer service initiatives also can help foster trust, because you really start tuning into people. So those are some of my initial thoughts about how to support organizational change. There's another question up here, John, that someone anonymous has put up. Since caring is essential, how do you treat someone who do you neither like nor respect?
Oh boy. Wow. With great difficulty. The thought I have had about this problem is that I'm not sure that liking is the best concept. It's nice when you like the patient. What I look for is something I can appreciate about the patient. And finding that may be a challenge. Even the patient's obstreperousness, you might find something feisty or something that you can appreciate, and connecting with around that. I think Gottman has made this very clear. Contempt is the death knell of a relationship, and Kant said love is optional and respect is obligatory. So I think if you really felt contempt, I don't think you could work with somebody. I'm just taking Gottman at face value that respect is necessary. And it might be hard to develop respect. No to give up, and of course, if you do give up, then what? These are really great challenges. I think this wonderful question, and thankfully, we work with extremely difficult patients, But this was a really, really rare problem at Menninger, but Menninger is not a typical institution either. So I can just say thank you. It's asking the right question. Michael, maybe you have something more.
Yeah, I have. I'll add to that. Yeah, I'll add to that. I think respect is foundational, and I actually have learned, and this comes from my psychoanalytic training, to try to approach my experience with curiosity. In other words, if I'm sitting with a patient and I'm noticing myself feeling dislike or even hate for a patient, I think it's part of my role and my function to be curious about what is it that's occurring at this moment that would engender this kind of feeling toward this patient. And what does it say about me potentially? There's something in me that I have to examine more privately and seek consultation and my own therapeutic work. And also, to what degree does it say something about the patient, that this offensiveness that this patient exhibits may be part of the problem in living, going back to this idea of problems in living. I remember, being in Houston, there was someone referred to me that, many people said they could not stand, and I guess they thought, well, we'll just send them to Michael and see what that's like. And I also found this person extraordinarily offensive, very derogatory towards ethnic groups, women, just difficult to stomach. And my best of moments was able to hold a framework in mind that, this person is doing the best they can based on this person's history. And it's part of my job to understand that and figure it out. What I came to learn was this man was profoundly lonely, and that his offensiveness served a certain kind of defensive function, that it kept him from getting close and therefore hurt by anyone. This is a man who had been left by his father as a boy. He put up this kind of very rugged, tough guy exterior, demeaning towards others. And, it took a lot of work. It took consultation with other people. I took my own consultation, my analyst, to be able to stay in a stance of remaining curious about this man's particular problems in living. And, I stayed focused on my task. My task was to be his therapist, and I agreed to that. And I didn't particularly like him. I did respect that his problems were real. And actually, I came to kind of like him over time, as I got to feel compassion for how lonely and sad he was, and that he had difficulty being able to even process that and talk about it. He became, as I think as many times in psychotherapy, we become less and more of ourselves. So he was less of an asshole at the end of treatment, but he was a little better.
Carl Menninger is reputed to have said that if you put an SOB into psychoanalysis, you come out with a well-analyzed SOB.
Yeah.
But maybe softening would be something that might have happened with him. I love the answer you gave to that challenging question.
Yeah. Here's another one, John. So how do you integrate these relationship factors with DBT and short-term programs that actively reduce the emphasis on a primary patient-therapist relationship?
All I can say is that, in all these treatments, DBT, behavior therapy, whatever, the common factor says that a good relationship is crucial to it. So I don't see that these are antagonistic to one another. And you use the word curiosity, interest in the person, understanding with the person, connecting with them, seeing how they respond to your help and so forth. Those are all relational factors. There was a big NIMH study on treatment of depression, and one of the conditions was medication. What they found is that some of the psychiatrists had whoppingly good effects with medication, no therapy, but they had a way of relating to the patient that made a big difference. So I would say these are not antagonistic.
Mm-hmm.
And that the challenge is to be connected compassionately and in a mentalizing way, to use our jargon, with what's going on with the patient.
Yeah, and I think, John, to add to that, I think that even though patients may not necessarily have an individual psychotherapy relationship, that doesn't mean that there are a lot of therapeutic experiences that the patient can have. A therapeutic experience of someone taking the time to really listen and attend to and respond to that particular patient's concerns. And I know that, here at Silver Hill, we have residential counselors who are working 24/7 with patients, who are hearing them out, who are providing comfort and soothing, who are and that kind of presence, that being with people, even if you aren't practicing a formal psychotherapy, John and I think contributes to what it means to be trustworthy. And I think there's an opportunity to, for all of us, residential counselors, financial accounts, dining room staff, therapy staff, psychiatry staff, nursing staff, social work staff, to ask patients, what is it that would help you feel more trusting of me in our work together? That question alone, and questions of that kind of nature, I think can move us in the direction of of opening up these kind of important dialogues. Let's see if there's any other questions. All right, I don't see any other questions. We are going to make these slides available, and I know some of you just saw a comment about asking about the research on the use of outcomes. Yes, there's a burgeoning research literature on the use of outcomes in psychotherapy. We're happy to share that with you. And if there aren't any other questions, I know I want to thank you, and then I'll turn over to John. I want to thank everyone for tuning in today to be part of this discussion, and we hope that you walk away with a richer perspective on, in my mind, a couple key things. One is the developmental process of becoming a therapist, the humility involved with lifelong learning, and being able to think broader than diagnostic specific treatments, to really thinking about the importance of the relationship and how much that matters here at Silver Hill, are some of the things I hope you can take away. John, anything you want to end with? Oh, I think we lost John.
Well, I want to thank you, Dr. Allen and Dr. Grote. Thank you for our attendees for joining us, and a reminder that in the Q&A, you'll find the attendance sign out and the evaluation survey. In addition to receiving the slides, a recording of this presentation will be posted on Silver Hill Hospital's website on Friday. This now concludes our grand rounds. Thank you and have a great day.